Good evening, all. I think we can start the meeting. We have enough number of participants. Prijo, sir, can we start the meeting, sir?
Yeah, we can start. Yeah.
Good evening, all. So welcome you to the academic session of Spice Route Kerala, planned for the month of August. So we'll be having a pediatric clinical case discussion today. So I welcome all the participants for this meeting. So the presenter for today is Dr. Fathima Lafna, who is a final year resident from KIMS Hospital. And the moderator for the session is Dr. Prijo. Dr. Prijo is a pediatric nephrologist and he's an academician at KIMS Health Trivandrum, who is very actively involved in all the academic activities of family medicine. So I welcome both Prijo sir and Fathima for the session. Over to you, Prijo sir.
Yeah, thank you. Fathima, shall we begin?
Okay, sir.
Yeah.
So, one second. So my patient details. Hrithik, 2-year, 5-month-old boy hailing from Marthandam, Tamil Nadu. And the informants are his parents, and the history seems to be reliable. The date of admission was 4th July 2022, and date of examination on 5th July 22. Presenting complaints were fever for 4 days ago, and swelling of face and both lower limbs since 3 days, and reduced urine output and frothy urine for the past 2 days. Now to the history of present illness. The child was apparently normal 4 days ago when the child developed fever, which was a low-grade continuous fever and associated with running nose and 2 episodes of vomiting. And the fever subsided in a day on giving paracetamol. The next day, the parents noticed puffiness of face and more around the eyes. And it gradually progressed to involve both lower limbs. And the swelling was found to be more in the morning. And they also noticed associated reduced frequency and quantity of urination and frothy urine for the last 2 days. There was no history of any discoloration of urine or painful urination, no history of abdominal pain, distension. There was no history of any joint pain or skin rashes, no history of loose stools or vomiting, no history of any cough, breathing difficulty, no history of jaundice or any bleeding manifestations like hematemesis or melena. Then no history of any insect bite or drug injection or itching over the skin. No history of any altered sensorium, headache or seizure-like activity. Then, course in the hospital, the child was admitted and started on medications, and he was advised fluid restriction, and the edema has started reducing and urine output was improving. So coming to the past history, child had a similar illness following a mumps infection and was diagnosed to have nephrotic syndrome on 2nd March 2022. That was at the age of 2 years and 1 month. And he was admitted and treated here at KIMS for 8 days and responded well to the treatment. The child was discharged on prednisolone 30 mg, and he was followed up. On follow-up, the child was doing well, and the steroid was gradually tapered to 5 mg on alternate days and was stopped just 1 week ago. That was also a screening test for tuberculosis then was negative. There was no history of any other hospitalizations, no history of tuberculosis, heart disease, liver disease, and or HIV infection or hepatitis infection. And antenatal, natal, and postnatal history. The child was a second child of a non-consanguineous marriage. It was born out of a spontaneous conception. Antenatal period was uneventful. And regular antenatal checkups were done, took iron, calcium, and folic acid regularly, and 3D 2 doses was taken, no drug or radiation exposure, no history of any gestational diabetes, hypertension, or UTI. And the scan done in all trimesters was said to be normal. And The child was born by elective LSCS, cesarean section, at 38 weeks of gestation. It was because the mother opted as she was having a history of valvular heart disease. And the birth weight of the child was 2.75 kg. The child cried soon after birth. Urine and meconium was passed in 24 hours. This was a history of neonatal jaundice developed on the second day of birth, and phototherapy was done for 3 days. And developmental history, developmental milestones all were for age was attained. Then coming to the dietary history, the child was exclusively breastfed till 7 months of age, and complementary feeding started with ragi at 7 months, and started sharing family diet at 1 year of age. There was no history of any food allergy. The child was advised to have extra protein and avoid extra salt intake and fried items after the first episode of similar illness. The child is getting currently about 905 kilocalories and 25 gram proteins per day according to 24-hour recall method. And the expected calorie was about 1036 kilocalories and 15.7 grams proteins according to the ICMR. There was a deficit of 131 kilocalories and excess of 9.3 grams protein. Immunization history. The child was fully immunized according to age up to according to the IAP schedule. And also after the previous episode of a similar illness, he was advised pneumococcal polysaccharide vaccine, and 2 doses of influenza vaccine was taken. The BCG scar was seen in the left upper arm, and no history of any serious adverse vaccine reactions. Coming to the family history, the child is a second child of non-consanguineous marriage, has an elder sibling, a 7 years old boy, in whom there is a history of seizure disorder. And mother has a history of had a history of nephrotic syndrome, which was diagnosed at 2 years of age, and remission was attained by around 8 years. And also mother has a history of mitral valve lesion, and for which no interventions were done. There was no history of any other significant illness in the family. But the socioeconomic history, the father is a businessman, mother is an MCA degree and currently not working. According to modified Kupuswamy scale, he belongs to upper middle class family, and they were living in a pakka house with good ventilation and good sanitation, and the drinking water was from one well, and there is no history of overcrowding. Coming to the summary, a 2-year, 5-month-old developmentally normal child immunized for age with a history of mumps infection and a nephrotic syndrome diagnosed, and at 2 years, 1 month of age, and a family history of nephrotic syndrome in mother, now presented with history of facial puffiness and both lower limbs edema since 4 days, following in upper respiratory tract infection and associated reduced urine output. Sir, shall I proceed?
Fathima.
Yes, sir.
Hello. Yeah, Dr. Prijo. Can you just go to the previous slide? I just got out of the connection. Just tell me, show me the previous slide. The previous one to this. Okay. Yeah. Now just tell me the summary.
What's that?
Yeah. Now you can summarize.
Okay.
I just wanted to see these. Yeah.
Okay. 2-year, 5-month-old developmentally normal child immunized for age with a history of mumps infection and nephrotic syndrome diagnosed at 2 years and 1 month of age, and family history of nephrotic syndrome in mother, now presented with history of facial puffiness and both lower limbs edema since 4 days, following in upper respiratory tract infection, and there was also history of associated reduced urine output.
Okay, all right. Shall we proceed with the examination?
Okay, okay, sir.
We'll discuss at the end of the examination as well.
Okay, sir.
Yeah.
Coming to the there was bilateral pedal edema present and second couple of lower third of shin. The vital signs, pulse rate was about 100 per minute, normal in rhythm, volume, character. There was no radioradial or radiofemoral delay, and all peripheral pulses were felt equally and bilaterally. The blood pressure was 100/70 millimeters of mercury in right upper limb in supine position. The respiratory rate was about 28 per minute, abdominothoracic. Saturation was 98% in room air. Right. And the capillary refill time was less than 2 seconds. The head to foot examination, head appears to be normal. No facial dysmorphism. There was facial puffiness with periorbital edema in both eyes. There was multiple hypopigmented macules present over face towards the sides. And there was no history of no malar rash. Eyes, ears, and nose was normal. Then oral mucosa, there was a single aphthous ulcer seen on right cheek. There was a fair oral hygiene, and the throat was normal. Neck was normal. BCG scar was normal. Chest, abdomen looked normal. In both lower limbs, there was pitting pedal edema to a level of lower third of shin. There was no any joint swelling or deformity. The skin, other than over the face, appears to be normal. There was no rashes or pyoderma. Nails, spine normal, and the genitalia appeared normal. Anthropometry, the weight of the child was 12.5 kilograms. That was between the 15th and 50th centile. Then height, 87 centimeter between 3rd and 15th centile. Then weight for height was above the 50th centile. In this, according to the WHO growth chart. And the mid upper arm circumference was 15 centimeters. And the body surface area was 0.55. Moving to the systemic examination, the gastrointestinal system, upper GI tract, the oral cavity, there was aphthous ulcer and a fair oral hygiene. Other than that, pharynx, tonsils, etc. was normal. Then abdominal examination, on inspection, the shape of abdomen was normal. Umbilicus was central and inverted. Flanks were free, and the skin was normal. And all quadrants moved equally with respiration. There was no visible pulsation, peristalsis, or any dilated veins. Palpation, on palpation, there was no local rise of temperature or tenderness. The liver was palpable about 2 centimeters below the costal margin, smooth rounded border, and the liver span was normal. Spleen was not palpable. Abdominal girth was 43 centimeters. And there was no other mass. Resonant note was obtained. No shifting dullness or fluid trail. On auscultation, bowel sounds heard about 3 per minute. No abdominal or renal bruit. Hernial orifices were normal. External genitalia was normal and no swellings noted. Then other systemic examination, respiratory system, upper respiratory tract appeared normal. And on chest examination, there was a normal vesicular breath sounds heard in all areas and no adventitious sounds. In cardiovascular system, the first and second heart sounds were heard normally and there was no added sounds. And central nervous system examination, the child was alert and there were no focal neurological deficits found. So to summarize as a whole, the 2-year, 5-month-old developmentally normal child immunized for AIDS with a history of mumps infection and nephrotic syndrome diagnosed at 2-year, 1 month of age, and a family history of nephrotic syndrome in mother, now presented with history of facial puffiness and both lower limbs edema since 4 days following an upper respiratory tract infection, and it was associated with reduced urine output for the past 2 days. And on examination, the child looked tired. There was stable vitals and hypopigmented macules were found on the face. There was periorbital edema of both eyes and bilateral dye, and systemic examination were within normal limits. So about the diagnosis, nephrotic, probably nephrotic syndrome, the first relapse and steroid dependent, probably infection induced, and without any complications, no atypical features, fully immunized up to age, and adequate nutrition and developmentally normal.
Okay. Okay, thank you, Fathima. So I'll ask a few questions and we'll start. This is not just for Fathima, and we'll discuss as a whole. So anybody in the audience who wants to answer or ask any questions can also ask any questions. So, I think the diagnosis is very straightforward because it is a known case of nephrotic syndrome, isn't it? So, first things first. So, can somebody define and tell me what nephrotic syndrome is? The diagnosis of nephrotic syndrome.
Sir, please once more. I couldn't.
Yeah, no, what can somebody define nephrotic syndrome? How do you define nephrotic syndrome? Or how do you diagnose nephrotic syndrome? Am I audible?
Yes, sir. Nephrotic
Yeah, yeah.
syndrome, there will be massive proteinuria,
Okay,
then associated edema, hypoalemia, and there can be associated hypercholesterolemia.
okay. Why is there hypercholesterolemia in these patients?
Increased
Because
production.
since there is beta lipoprotein synthesis, because of hypoalbuminemia stimulates beta lipoprotein synthesis.
Yeah.
And also
So basically what it
the
means in,
degradation is
yeah, continue.
also there is decreased breakdown of lipids.
Okay. So basically what it means is that in simplified terms, when the body is losing proteins and the protein is albumin, the body tries to compensate by increased production of other proteins, and cholesterol is one such protein. So you can have hypercholesterolemia. What is another cause for hypercholesterolemia in these kind of patients? Anybody? Known case of nephrotic syndrome. In a known case of nephrotic syndrome who has already started treatment, can we see hypercholesterolemia? Anybody?
Steroid induced.
Sorry?
Steroid induced.
Yeah, correct. You can have steroid induced hypertriglyceridemia. You can have. So steroid is also a side. I mean, steroid can, as a part of its adverse effect, can also cause hypercholesterolemia. You must keep that at the back of your mind, especially when it's a known case of nephrotic syndrome. All right. So nephrotic syndrome, the diagnosis is established by nephrotic range proteinuria, hypoalbuminemia, edema, and hypercholesterolemia. Okay. Can you define this biochemically? When you say hypoalbuminemia, below what level? When you say hypercholesterolemia, up to what level? And when you say proteinuria, up to what level?
Less than 2.5 gram per deciliter.
Okay. But I think that's in adults. How do you say in children?
More than 40 milligram per meter square per hour protein in urine.
Correct. So you can have, so what is a normal proteinuria? What is a normal level of proteinuria you can have?
Less than 4. Less than 4.
Correct. So yeah, so all of us will have a proteinuria level of less than 4 for 4 mg per meter square. In the case of nephrotic syndrome, you'll have proteinuria of more than 40 mg per meter square per hour. Okay. In other terms, you can have a proteinuria of up to 150 mg per day for a normal person, and above that it means it's a nephrotic range proteinuria. In terms of urine protein create ratio, how can you define proteinuria?
More than 2 mg per. More than 2:1.
Yeah, no, not more than 2:1. A urine protein to creatinine ratio of more than 2 is defined as a nephrotic range proteinuria. So what is any value between 0.2 to 2? I mean, what is normal? What is the normal protein creatinine ratio?
Less than 0.2.
Correct. What we must remember is that up to infants up to 2 years, and in children up to 2 years of age, you can have an upper limit of up to 0.5, and some books say even 0.6. A protein grade ratio of 0.5 and 0.6. So very often we'll find children being brought by parents, and somebody would have done a test, and they would say urine protein grade ratio of 0.4 or 0.5. The child may be just 1.5 years, 2 years of age. That is absolutely normal. Up to 2 years of age, you can take your upper limit of normal as at least 0.5 or 0.6. After that, the upper limit of normal is 0.2. So normal human beings protein grade ratio should be ideally less than 0.2. So if you say 0.2 is the upper limit for normal children, and for nephrotic syndrome, the range is above 2. So what about the range? What about the proteinuria levels between 0.2 to 2? Anybody?
Non-nephrotic range.
Subnephrotic proteinuria.
Correct. Good. So that is basically non-nephrotic range proteinuria, which means the proteinuria is significant, but it is non-nephrotic range. This kind of proteinuria you can get in cases of glomerulonephritis. You can get an acute kidney injury. You can get a lot of other conditions. You can get a non-nephrotic range proteinuria. Nephrotic range proteinuria should ideally be above protein create ratio of more than 2. And what should the albumin levels be if you want to diagnose nephrotic syndrome?
Less
Serum
than 3.
albumin levels.
Serum.
2.5.
Okay, I think most
2.5.
books will say, most books say less than 2.5 milligram per deciliter. Now, as I understand it, a protein create ratio is not a test which is available everywhere. So many people do urine dipstick. Correct?
Yes.
So on urine dipstick, how will you diagnose? What are the parameters for diagnosis of nephrotic syndrome? Along with your hypercholesterolemia and edema and hypoalbuminemia, that is the urine albumin. I mean, the serum albumin less than 2.5. What is the urine dipstick value?
3 plus and 4 plus.
On
3 plus or 4 plus.
so if I do urine dipstick today and I'm getting 3 plus, am I nephrotic syndrome?
3 first.
Consecutive.
Correct. So the important thing is you must have urine dipstick showing 3 plus or more on 3 consecutive days, along with edema. But now plus or minus, now the parameters have shifted and they've said plus or minus edema, along with hypoalbuminemia and hypercholesterolemia. Now, what does when you say urine dipstick 1 plus, 2 plus, 3 plus, and 4 plus, does anybody know what does it correspond to? Because it is a very rough estimate. It's only a very it is just sensitive for proteinuria, but we cannot define exactly what is the amount of proteinuria. And does anybody know what does 1 plus, 2 plus, 3 plus, or 4 plus correspond to?
1 plus is approximately 0.3 gram per deciliter.
100 microgram.
Okay, 2 plus.
1 to
2 plus is 1 gram.
100 milligram.
So 3 plus.
3 gram.
100 to 300 milligram.
Correct. So roughly, what we say is when we say 2 plus, it means about 100. When we say 3 plus, it means 300. When we say 4 plus, it means 1000 milligrams or more. The problem with using a urine dipstick is because if you get urine 3 plus, for example, I'm doing I am a child. For example, I am a patient with nephrotic syndrome, and I'm doing my urine dipstick today, and I'm seeing urine 3 plus. So urine 3 plus basically means that my proteinuria is above 300 milligram per deciliter. But I could be doing the test again after 1 week, but I can still be 3 plus, which means my value could be anywhere between 300 to 1000, but it doesn't give me a defined value of proteinuria. So that is why we use a 24-hour urine collection for protein, or we use a spot urine protein create ratio, because it helps to correctly quantify. When you use a spot protein create ratio, it completely tells us for example, I could be when I'm testing today, I could be a urine protein create ratio of 40, and 10 days later I could be testing and I could be 30, but both on the dipstick will show 4 plus, but actually there is a reduction of proteinuria by 10. It would have reduced from 40 to 30. So ideally, it is better if you can use a urine protein create ratio when available. If it is not available, of course, you can use a urine dipstick. Am I clear? Hello?
Yes.
Yeah. So now second question. So you've mentioned in your diagnosis that there are no atypical features in this nephrotic syndrome. So what are the atypical features of nephrotic syndrome?
Age of onset less than 12 months.
Hypertension.
Okay.
Hematuria,
Anything-
Hypertension, gross
Anything else?
hematuria or persistent microscopic hematuria. Then
Correct. Very good. So what you have to understand is many nephrotic syndromes you can have microscopic hematuria at the onset of illness. Okay,
Yes.
because there is a glomerular injury. You along with proteinuria, you can have some amount of microscopic hematuria. What is important is whether when you follow this up after the course of treatment, if the microscopic hematuria subsides or not. If it doesn't subside, then it is important, because then if there is persistent microscopic hematuria, we have to evaluate and find out the reason for that. Because nephrotic syndrome per se is not a disease. It can be a manifestation of another disease also sometimes. So the other atypical features are, as you said, if the age of the child is less than 1 year, or the age of the child is more than 10 years. Now, some books say up to more than 12 years as well. If you have hypertension at onset of illness, if you have an AKI, if you have an acute kidney injury at the onset of illness, all these, if you have hypertension at the onset of illness, or if you have gross hematuria, as somebody said, if you have gross hematuria at the onset of illness, also is an atypical feature for nephrotic syndrome. And what is the significance of atypical feature of nephrotic syndrome? Why do we want to know?
Do a renal biopsy. Renal biopsy and as the treatment varies.
Correct. Because all these will be indications. At the end, if the patient is not responsive to therapy, we should be keeping these in mind, and these may be indications to plan ahead for a renal biopsy. So now, because we know that the illness is nephrotic syndrome, it's easy for you to diagnose nephrotic syndrome. But can you tell me, if this was a child who presented with first onset nephrotic syndrome, how will you diagnose that it is a renal problem?
The nature
How
of
would
the
you understand?
edema.
Okay, by nature of edema, what do you mean?
Facial
Nature of
puffiness
the
followed
edema,
by the rest.
First, then followed by pedal edema, and then it comes to the abdomen.
Correct. So what is the difference between the edema of renal etiology and what is the edema of CVS etiology or GIT etiology?
In CVS, it usually starts with pedal edema, and
Okay.
GI, it starts with ascites, means abdominal ascites.
It starts with ascites. And the clinching feature of renal etiology is that typically parents say that the edema is more in the morning. And as the child becomes ambulatory, the fluid comes to settle down in the dependent part. Basically, the fluid comes down to settle in the dependent part. So after sleeping, the edema will be more in the upper zones. That is, you will find more periorbital edema and upper limb edema, which means the child has slept overnight. And as the day progresses and as the child becomes ambulatory, the fluid comes towards the dependent area and the edema apparently begins to reduce. Right?
Yes, sir.
Yeah. Okay. So then you mentioned certain specific things in your history. You said that there was no history of rash. There's no history of any skin lesions. There was no history of joint pain. Why is this important? Why is these histories important?
Some other conditions like HSP, means phenolphthalein and all can present with skin rashes and joint pains.
Okay. Anything else? Okay.
Other secondary causes like SLE, vasculitis.
Okay. Okay.
Then
Anything else?
I mean, to differentiate like acute
Okay.
Preceding infections, preceding skin infection in case of glomerulonephritis.
Okay. So what you're saying is correct. What you have to do, you may just have to refine the answer in the sense that now you don't expect a 2-year-old child or a 2.5-year-old child to actually have lupus nephritis. So it is true that when you say pain, one DD or one differential is SLE or systemic erythematosus. There is a possibility of manifesting as nephrotic syndrome, but that is more in the case of female children and more towards the adolescent age group. Maybe you can say 8 or 9-year-olds may begin, but it is important to keep that diagnosis in mind. The other DDs, as you said, one is HSP henoch-Schondlin purpura, which also has possibility to develop to present as a nephrotic syndrome. And this is where I said before, nephrotic syndrome per se may not always be a disease. It may be a manifestation of the disease. So you can have an HSP henoch-Schondlin purpura, which is presenting as a nephrotic syndrome. You can have a systemic lupus nephritis presenting as a nephrotic syndrome. Any other differentials you have? One more important condition that can present as nephrotic syndrome. Actually, there are two, but I'll say both. But at least can you say one? This also presents with you can present with gross hematuria, recurrent gross hematuria. You can have nephrotic range proteinuria. Usually presents in the adolescent age group.
Hemolytic
Second decade.
hemolytic uremic
Okay,
HUS.
hemolytic uremic syndrome
syndrome.
is a good HUS is a good shout, but the problem is it does present with gross hematuria and nephrotic range proteinuria, but it's more severe usually in its onset. But it's a good differential. Anything else do you have in mind?
Nephropathy.
Sorry.
IgA nephropathy presents with hematuria with
Correct.
fight.
Correct. You can have IgA nephropathy. Okay, you can have IgA nephropathy. IgA nephropathy it's very similar to HSP nephritis. In fact, some people say, some books or some literature says that the both are very closely interlinked. That is HSP nephritis and IgA nephropathy. Both can present with microscopic hematuria or gross hematuria. Both can present with proteinuria, nephrotic range proteinuria. Both can present with renal failure. Both also present with joint pain, rashes, and so on and so forth. And the diagnosis exclusively by biopsy. So IgA nephropathy is one that you must keep in mind. Anything else? Special points to somebody who can answer this last question. Anything else you want to keep in mind? Family history of, if you see there's a family history of nephrotic syndrome or a family history of renal failure, of a mother who has got ophthalmology issues or hearing issues.
Alport syndrome.
Correct. So many of at least in my own private practice, I've seen a couple of patients who've come initially who present with hematuria, nephrotic range proteinuria. We treat as nephrotic syndrome, but ultimately they'll turn out to be resistant nephrotic syndrome. And when you do a biopsy, it turns out that the patient is actually an Alport syndrome. So Alport's is the last DD. So you must always ask also if there is a family history of any renal disease, if there's a family history of deafness, if there's a family history of any ophthalmologic issues. Very important to keep in mind about Alport syndrome. Although Alport syndrome must be a last DD for proteinuria, because it is the first differential for one of the first differentials for persistent microscopic hematuria. But you can have proteinuria as well. So you must bear in mind that there is IgA nephropathy, there is HSP nephritis. As somebody said, there is a possibility of HUS, and also there is a possibility of Alport syndrome and lupus nephritis. And as Fathima also said, vasculitides. So what are the vasculitides you want to keep in mind?
ANCA-associated vasculitis.
Correct. So in simplified terms, you can have ANCA-associated vasculitis.
Small vessel vasculitis.
So that is an entirely different topic, but present with nephrotic range proteinuria. And this is why during the initial evaluation, if you see anything abnormal, that is an abnormal age of the child, abnormal age of presentation, if you see, for example, the child having persistent microscopic hematuria, or you're seeing that the child has got dysmorphic RBCs in the urine, all these are just faint signs or subtle clues that it may not be your regular nephrotic syndrome. Agreed? Hello?
Hello, sir.
Yeah.
Yes, sir.
So my next question. So you got the idea. You've taken the history of the patient. You've got the idea that it is a nephrotic syndrome. Now, how are you going to diagnose? Clinically, now you've made a diagnosis by lab investigation. How are you going to case of nephrotic syndrome? What are the investigations you would send and why?
So,
And bear in mind
like,
that this patient Hrithik has come with edema, because so your investigations are also going to govern how you want to treat the patient.
yes, sir.
Yeah, tell me.
Complete blood count can be done to rule out
Okay, and
infections.
tell me why you do and
Rule out infections.
okay. Anything else? Any other reason
Then,
why your
presence
CBC
of
will help you?
anemia may be present in case of chronic
In case of?
kidney disease.
But we are not talking about chronic kidney disease here.
Yes, sir. Yes,
What?
sir.
Why would PCV? Okay. Why would HB and PCV help you?
Concentration.
Correct.
Hemoconcentration.
Very good. So what we for is a rough clue. When you see the hemoglobin is 12 and the PCV is, for example, 36, we know that the child is almost euvolemic. When we see edema in the patient, then you see HB of 12 and a PCV of, let's say, 30. This means there is hypovolemia. I mean, sorry, the child is having What is it? Hemodilution.
Hemodilution.
Yes.
Hemodilution. Chemoconcentrated
Hemodilution.
CCV should increase. Yeah. So that will govern if you want to start diuretics or not. Okay. So that is very important. So you do HB and you do PCV. Any other reason why you want to do HB and a peripheral smear for this patient? For a patient who is coming like this, any other reason why you want to do a peripheral blood film, why you want to do an HB? Somebody said this before. Correct. Very good. So if you are suspecting a case of HUS, you would also want to see the HB and the platelets, and you want to do a peripheral blood film to look for features of microangiopathic hemolytic anemia. So that for that one purpose, peripheral smear would be good. Any other reason? See, because on this level, you must know why you are sending an investigation. No investigation is routine. So if you're sending a CBC, you must know. So by any other reason why you want to send CBC? Let us suppose this child is an 8-year-old girl or a 12-year-old girl. Is CBC important for this patient?
Second.
Sorry?
So secondary causes also have to be ruled out, like malignancy, etc. Important peripheral smear.
Okay, malignancy, good. Anything else? I gave you the clue. Adolescent girl. Lupus. Always remember lupus. Okay, because in lupus with presenting with nephrotic syndrome also, what you will find? You can find anemia, you can find leukopenia, and you can find thrombocytopenia. Right. So again,
Yes.
in this case also, your CBC and your peripheral blood film is very important. Right. Okay. So what other investigation do you want to send?
Electrolytes.
No, start from blood. Okay, from blood. Okay, you want to do
Okay.
electrolytes. Okay, so what electrolytes do you want to send?
Sodium, potassium.
Okay. What information is sodium going to give you? What is sodium and potassium going to give you? What is the interpretation? Let me tell you. I am seeing this patient with a sodium of let's say 122, and there is a potassium of 5.6. What information are you going to get?
Dilutional hyponatremia and hemolysis.
Very good. So dilutional hyponatremia. Okay, so you must remember all low sodiums does not mean it is dilutional hyponatremia. If you're seeing that the child seems to be severely edematous, and if you're seeing that the child is having a sodium of 122, the first thing that should come to your mind is, of course, dilutional hyponatremia. Okay, so why is the potassium 5.6? Potassium.
Hemolysis.
Okay, that is one reason. That is a problem of sampling error. Any other reason why this child's potassium could be 5.6 or 6, let's say?
Acute renal failure.
Renal failure is a very gross way of saying it. It's not a bad answer. When the child's urine output falls, your potassium levels will increase because potassium actually treated out. So because of when there is a reduced urine output, you can have an increase in the serum potassium. So such a value of 122 sodium, potassium 5.6 or 6 or whatever should give you a clue that this child has got a very reduced urine output and he's dilutional. Okay. Any other blood test?
Then cholesterol, serum albumin.
Okay, you want to do a serum albumin. You want to do a serum albumin, you want to do a serum cholesterol. Then what do you want to do? You want to do a total protein.
Creatinine and blood urea.
Okay, you want to do a creatinine and blood urea. Then what do you want?
Urine routine examination.
Okay, urine routine. So why is urine routine important?
Iron. Presence of protein, then red cells and casts can be seen.
Good. So because the question which always PGs will ask is if you're doing urine protein ratio, then why you need to send a urine routine. So the reason why we want to send a urine routine is because along with protein, we want to look for casts and we want to look for RBCs. Because if you see RBCs in urine or if you see dysmorphic RBCs, it is that you must keep in mind. And when after the course of treatment, you must see whether it is subsided or not. And if it is persistent, it may be a reason to follow up and may need planning for biopsy. Any other investigations you want to send?
Special investigations.
Okay,
Maybe we
special
can do
investigations. Tell me the special investigations. I'm sorry, it's not audible. Hello? Hello? Hello?
Additional investigations like C3 levels, tuberculin test. Tuberculin
Okay, you want
test.
to do C3, C4?
Hello, sir. Yes, sir.
No, you're telling
Compliments.
you want to do C3,
Yes.
C4?
Yes, sir.
Why?
Yes. C3. If there is any atypical features, just.
No, this is for Hrithik. For this patient, would you want to do
Okay,
C3,
sir.
C4?
Okay. No, sir. No, sir.
Ideally, when do you want to do C3, C4?
When there is presence of any hematuria or
See, actually, now this is something that I would like.
Features suggest.
Very good, very good. So this is, see, actually, there is a subtle what you must understand, and what I want to tell you as students is very good, very good. What I want to tell is, see, very often what we do in the peripheral practice system, this is just a teaching point. Very often what we do in the peripheral practices, when the child presents with edema, we are really not sure whether the patient is nephritic syndrome or nephrotic syndrome. Okay, so even I've been guilty of doing this. So when we don't know whether it is nephritis or whether it is nephrotic, what we do is we just tend to send off all the investigations, including C3, C4, okay, and even the nephrotic parameters, cholesterol, albumin, protein. The thing is, the end result is actually C3, C4 is costly, burns a hole through the patient's pocket. And anybody who sees the patient later will only get the idea that the clinician was not confident to make a diagnosis of whether it is a patient of nephritic syndrome or a patient of nephrotic syndrome. Now, as Fathima said, when you suspect a nephritis element to your nephrotic syndrome, because you can have a nephritic onset nephrotic syndrome. If you are having a nephritic onset nephrotic syndrome, yes, you are allowed to do a C3, C4. In an out and out nephrotic, I'll give you a few clues when you can suspect nephritis and nephrotic syndrome. One of the best clues is that nephrotic syndromes are usually edematous. Your nephritis patients will have proteinuria, but they will, as I said before, they will have non-nephrotic range. They can have nephrotic range proteinuria, but they usually have non-nephrotic range proteinuria, and the edema is not very obvious in glomerulonephritis. The edema is not very obvious. They will usually have at least 30 to 40% will have a gross hematuria at the onset. And as Fatima said, you can have hypertension or a small AKI at the onset of illness. But don't always go or fall into the trap of hypertension. The problem of diagnosing hypertension in children is because hypertension is sometimes overdiagnosed, because in extreme small children, the patient will be crying when the BP is taken, and when the BP and if the patient is crying also, you can have a higher BP. Number one. Number two, if the patient is having a volume overload, okay, the patient is severely edematous, even then the patient can have hypertension. So that may not be directly related to the nephrotic syndrome. That may be related to the volume overload that the patient has, which is causing the hypertension. So you must be able to assess this, isolate this individually, and see if there is a reason to suspect a nephritic syndrome. Easiest thing is, what I would say is, if the patient has got, as she said, if the patient has got hypertension, if the patient has got some dysmorphic RBCs or even some microscopic hematuria, and or at the worst, if the patient has got gross hematuria, definitely you must do a C3, C4. Clear? I would also do a C3, C4 if the patient is having any atypical features, like if the age of the child is more than 10 years, less than 1 year. Also, I would do complements. But otherwise, for a routine nephrotic syndrome, complements is not actually advised. Hello?
Yes, sir.
Yeah. What other investigations would you want to send?
Okay, sir.
Hello?
If any features of infection cultures, urine culture.
Very good. So you have to send a blood culture or a urine culture, especially for this patient, because the patient presented with a probable infection-induced relapse. We don't know the source of infection, so it could be spontaneous bacterial peritonitis. So you must send a blood culture, you must send a urine culture, and you must send a sepsis screen. Anything else you want to send?
24-hour urine protein.
Yeah, this is interesting actually. But the thing is, you don't need to see the concept of 24-hour urine protein measurement is valid for adults. We cannot do it for children, so that is why we've extrapolated that and we have done a spot protein create ratio. Because for 24-hour urine collection, the child has to be catheterized. Right? Most children will not allow to be catheterized for 24 hours. So we do usually spot protein create ratio, which is a extrapolated value of that 24-hour urine value. Right. So now I'll a few things I'll discuss later. Now, okay, so you've understood that this is a relapse of nephrotic syndrome. So how do you want to treat this child? How do you want to treat this child? Hello.
Hello, sir.
Yeah. Tell me, how do you want to treat this child?
The non-pharmacological and pharmacological measures.
Very good. Okay.
Sir, can you...
Yeah. I can say. Tell me. What are the non-pharmacological measures?
Audio is very thick. Fathima, can you switch off the video? And your audio will become more clear.
We have to advise regarding a high protein diet.
Salt restriction.
And normal salt in diet.
Okay, who told normal? Who told normal salt? Who's selling normal salt?
As there is edema, we have to restrict.
No, who's saying normal salt? Fatima, no? Did Fatima say normal salt?
Yes, sir. I told first, but
in your history you said. But in your history you said the mother told reduce salt. So should we take reduced salt or should we take normal salt? Simple question.
Hello, sir.
Yeah. So should we take reduced salt or normal salt?
No, sir. That was in remission. It was normal salt.
Okay. So when the child is having relapse or when the child is having first episode nephrotic syndrome, how much salt do they take?
No extra salt.
No extra
Normal
salt.
so added salt.
So the consensus is no added salt. Hello?
No extra salt.
Correct. So I see many books will say salt restriction and extra protein. Okay. Now what I'll tell you from personal experience, there is nothing called as added protein. Okay. Parents tend to add extra protein in the diet when the child has got a relapse, but all you're producing is actually costly urine. Okay. Because what you're giving ultimately will get out. That is the thing. So there is actually no need for extra protein intake. What they're actually having, a regular protein intake that you can have, which is about 1 to 1.5 gram per kg for this child. Okay, so I would never advise to have extra protein because it doesn't do any good. Now, with regards to the concept of added salt or not, I always tell patients the important thing to remember is not to add extra salt. Okay, what you should have is regular salt in your diet. You should not restrict the salt because see, so while some books say restrict salt and some adults say restrict salt, what we must do is we must understand to a certain extent that these are children. When you restrict salt in their diet, their oral intake may reduce. Not only that, these children, as I said, many of these children already have dilutional hyponatremia. Sodium is in the range of 120, 122. Himself, this patient had a sodium of 120. So when you restrict salt further, when you tell the parents to restrict salt, what is going to happen is the sodium will reduce further and ultimately the child will have seizures. The important thing to remember is there should be no extra added salt. And then the last thing, try to avoid oily or fried items, which is what we have advised the mother to do, which is what she told. So that is the non-pharmacological measure. Anything else you want to give? you want to say to regarding non-pharmacological management?
So what about the fluid intake?
Correct. So how much fluid you want to give in a day? How much fluid you want to give
400
in a day?
ml per meter square per day plus previous day's urine output.
So what if the child came today? So how will you assess the fluid?
Yes, sir.
How will you do it? The child is coming to you right now, evening. So how are you going to say how much fluid to take?
Maintain negative fluid balance.
Yeah, so that is one way of doing it. The idea is to maintain a negative fluid balance, but it should not be too negative. It should not be that you're giving 400 ml and the child is voiding 1.5 liters, because then the child will develop AKI. Okay, the idea is to have a negative fluid balance by maybe about 400 to 500 ml. An easier thing to do would be you say 400 ml per meter square per day for the first day. And then you assess how much is the output. So I'm assuming everybody knows how to calculate the BSA area. So 400 into the body surface area, it will tell you how much ml of fluid you need to give in the day. Then you assess overnight. If the child is passing a higher volume of urine, as somebody said, you must maintain a negative, but it should not be too much negative. Okay. So accordingly, you must reassess the patient every 6 hours and see whether he needs an increased oral intake or not. Otherwise, he will develop AKI if the child is having a severe, increased urine output. Am I clear?
So how to calculate the BSA, sir?
BSA would be height in centimeters into the weight in kilograms divided by 3,600, the whole square root. I'll repeat again. The body surface area calculation is what we call the Mosteller's formula. It is height in centimeters into weight in kilograms divided by 3,600. And this value, you must do square root. The whole square root of this value will give you the body surface area.
Okay, sir. Okay, sir.
Yeah. So when you do, so that value, you will get a value. For this child, it will be about 0.7 or 0.6. So when you want to calculate the total fluid intake for this child, it will be 400 ml per meter square for this child means. For example, I'm saying if the body surface area is 0.5, it will be 400 into 0.5, which will be 200 ml. I'm just saying an example. I'm just using an example. Okay. Hello.
Yeah. Okay, sir.
Yeah. Okay. So now what else do you want to treat? How else do you want to treat this patient?
Diuretics.
Okay. Diuretics. You want to give diuretics. Okay. Then I'm saying, I also want to say when you said serum albumin, I want to say the serum albumin is 1.8. How do you want to treat the patient? Anybody? Do you want to give serum? Do you want to give albumin? Do you want to give albumin infusions?
Only if severe symptomatic hypovolemia.
Symptomatic Very good. So if the albumin infusion is there in the schedule for giving as part of pharmacological management of edema only if serum albumin is less than any value. What is the value below which you must consider serum albumin infusion? Anybody knows?
1.5.
Correct. So if the albumin level is less than 1.5, definitely you must consider serum albumin. Any other reason why you must consider serum albumin is if the patient presents with shock. Because in the case of shock, if the patient presents with shock, you may not be able to give IV fluids. Okay. Because the patient may already be edematous. So there will always, and if the child is already having in shock and if the patient is having an AKI, you may have a problem with regard to giving IV fluids because it has already got reduced urine output. The child has an AKI. And if you push in IV fluids at the time, the patient can go into fluid overload and pulmonary edema, and the child could collapse. So in these kind of situations, you can give an albumin with a Lasix, and you can give a trial. So these are the indications for giving an albumin infusion. Correct? Understood? Now, I also want to tell you this is just for those who want to know. There is another reason when you can give an albumin infusion. Okay. This is when, even though the albumin may not be less than 1.5, it can be 1.6 or 1.7, and you're giving diuretics continuously, but the child may not be responsive. This is also a case scenario where we can give albumin infusion. Why is because, see, most of your diuretics are actually albumin bound. So you have albumin, you have different kinds of diuretics, like you have furosemide, you have spironolactone, you have thiazide diuretics. Each of these affects a different part of the tubule. So these medicines affect different parts of the tubule by being bound to albumin. But if the patient already does not have albumin or protein, so these medicines cannot go and act where they need to act. So in case of diuretic resistance or diuretics are not being effective, you can try a trial of albumin and see if by increasing the serum albumin levels, the effectiveness of diuretics can also be improved. This is another indication where there is possibility to give an albumin infusion. Clear?
Okay, sir.
Yeah. So the other medicines, as you can give, as I said, for the edema is you can give, of course, you can give furosemide up to 4 mg per kg, 1 to 4 mg per kg per day. You can give. You can also give as an infusion. You can give aldactone, okay, spironolactone. You can give. It is a potassium sparing diuretic. And that is another reason why you need to know the potassium levels before starting. Because if the potassium level is something like 5.6 or 5, you cannot give spironolactone because it is a potassium sparing antibiotic. So what potassium sparing diuretic. So what happens is, if you give potassium sparing diuretic and the potassium is already on the higher or upper range of level for normal, the potassium will build up. So at that point of time, you must not give. Then another reason for wanting to know the serum baseline electrolytes is if you want to give thiazide diuretics, like for example, if you want to give a diuretic like metalazone. Metalazone is notorious for causing hyponatremia. So the patient already has a sodium of 125 and all, you do not want to give metalazone because what it's going to do is going to worsen the hyponatremia. So these are the reasons why you need to know serum electrolytes. So each lab that you send has got a reason. So when you do sodium potassium, these are the reasons. It will govern what kind of diuretic you want to use. Usually, Lasix is the most safest. Lasix is the easiest diuretic to start because if the patient is having a dilutional hyponatremia also, you can give Lasix. It is safe and sound. And if the patient has got a higher potassium value to begin with, again, with furosemide, the potassium levels will fall. After that, depending on the lab values, depending on the trend of sodium potassium, you can decide whether you want to add aldactone, spironolactone, or whether you want to add a thiazide diuretic. And if nothing is responsive, you can go in for albumin infusions. But we didn't start with this. What is the most important medicine?
Steroids.
Steroid. So my teachers used to tell me that steroid is the best diuretic. So if you want to start steroid, what is the dose you want to start?
60 milligram per meter square per day.
Very good. I really appreciate you saying that. Because most people would say 2 mg per kg per day. Now, there is a concept, okay? Now, when you go out and practice, you will understand. So many physicians find it easier to calculate 2 mg per kg. Because if the child is, for example, 10 kg, so you just have to give 20 mg. But the problem is when you calculate as per body surface area, when you calculate 60 mg per meter square, the dose may always be slightly higher. There may be a difference of at least 5 mg or 10 mg. While there are people who say that difference is not so much, my personal preference is always to calculate based on body surface area and then calculate as 60 mg per meter square. Because if the child fails treatment, at least you don't have to think that we didn't give the higher dose and that is why the child did not respond. So better is always calculate as per 60 mg per meter square per dose and then treat. So if this child is having a first episode nephrotic syndrome, how long do you want to treat?
For 6 weeks.
Yeah, 6 weeks. And if the child is in remission, then you will give for
40 milligrams per meter square.
Again for
alternate days for 6 weeks.
Okay, as a single dose. Please remember this as a single dose.
Single morning dose.
This is another, single morning dose. Because the complication of giving divided doses is that there is an increased risk of adverse effects. You'll find more Cushingoid features, more features of hypertension when you give a divided dose of steroids.
Okay.
So, and how do you want to stop the steroids? Do you want to taper and stop, or you want to just directly stop?
Tapering, according to.
Okay. So this is important for you from an exam point of view. See, the most recent guidelines as per Indian Society of Pediatric Nephrology says that you can stop the steroids directly after 6 weeks. But the previous guidelines and the KDIGO guidelines and what is given in Nelson textbook of pediatrics up to now is that you must taper and stop the steroids over a period of a couple of
5
months. Yeah. So you must slowly taper the steroids and stop. Now, if the child is in relapse, now this child, Hrithik, is a patient who is having a first relapse, right? So in this case, how will you treat the child? You want to give for 6 weeks steroids?
Till remission, till he achieves
Correct.
remission.
Correct. Very good. So you want to give until he achieves remission. Then you will switch over to alternative. You will give full dose steroids, make him attain remission, switch over to alternative steroids, and then give rapid taper of steroids. This rapid taper of steroids is actually, there is no given guideline. What they say is at least by 5, you can reduce the dose by 10 mg, 10 mg, 10 mg, 10 mg every alternate, or by every 2 weeks and directly stop. Okay. Am I clear? Any doubts? Any doubts so far? I don't know if I'm going fast or not. Any doubts? Hello? Hello?
Hello, sir.
Okay, okay. So what are the complications? What are the complications we're expecting in this child?
Infection. Presence of infection.
Okay, infection. Okay. Why infection?
Loss of immunoglobulins.
Okay, very good. So there is a loss of immunoglobulins. Correct. Steroid itself is an immunosuppressant.
Loss of complements, immunoglobulins.
Correct.
So,
Correct. Any other complications? Any other
thrombotic
complications?
complications.
Correct. You can have thrombotic complications. You can have infections. Anything else?
Ascites.
Hypophilemia and renal failures.
Renal failure. Okay. Peritonitis. Anything else?
Steroid toxicity.
Steroid toxicity. Okay. So this is important, okay, because when you start the medicines for the parent for the children, it's always important to tell the parents what adverse effects you are likely to encounter. Likely adverse effects you are likely to encounter for the child are Cushingoid features. Okay, you must be able to tell the parent that Cushingoid features are expected features, and this will gradually subside as the steroid dose comes down. The other side effects we are expecting is there is an increased chance of higher appetite. Okay, most parents will come and tell you back that the appetite is high, the child is eating a lot, but that's all normal. Because those steroids comes down, the appetite will also reduce. So you can have a higher appetite. You can have some behavioral or mood disturbances. Some children will tend to be aggressive, hyperactive. Some children will tend to be moody. We can have hypertension. Most children, many children will have hypertension. Some children can develop diabetes later on. Certain children have rickets-like features if they are on steroids for a long duration of time. Okay, so this is why when you start steroids, we also usually give calcium also in these children. Okay, and we also supplement for vitamin D. Hello.
Okay.
What about vaccination? What about vaccination for these children? If the parents are asking you regarding advice regarding vaccination, so how do you give? What would you advise?
Vaccine should be given, no? Live vaccine.
No live vaccine.
Yeah.
Within.
At least
12 weeks.
For 4 weeks, or while they are on.
While they are on treatment, steroid treatment,
steroids.
they should not be given any live vaccines.
So all of you are correct,
So-
actually. So what we used to say before is
For
up
4
to
weeks.
12 weeks, up to 12 weeks of
weeks.
finishing treatment, you must not get a live vaccine. Okay, but
Okay.
this is an old guideline, and we are living in a new world. Okay, so the guidelines have slightly changed, where they say if the vaccine is really important, it depends on what the dose of steroid is. This is not for exam purpose. This I'm just telling you. If the child is on a dose of 1 mg per kg, you can suddenly stop the dose of steroid. You can give an important dose of the medicine and then restart the vaccine. But for all other purposes, for all exam purposes, what you must understand is no live vaccines for 12 weeks until the child has finished treatment. Your live vaccines are your MMR vaccine. There is varicella vaccine, which is also live vaccine. And always remember, oral polio vaccine is not to be given when the child is having steroids. Am I clear? Steroids are even if the patient is on alternative regimen treatment like tacrolimus, okay, which you give for steroid-resistant nephrotic syndrome. Also, you must not give oral polio vaccine. Clear? Because I have seen many cases which come back because the child is already immunodeficient. Then you're giving the patient is on steroid and tacrolimus, and then you're giving OPV. I've had a couple of patients, actually nurses' children, who come back as polio. Clear?
Okay.
Yes.
Hello. Yeah. So, what other vaccines do you want to give? What vaccines will you ask to give?
Pneumococcal. Influenza.
Correct.
Where is
So if you notice this child who's on my follow-up, he's
Yes.
already been immunized with the pneumococcal vaccine. The schedule you must be up to
Polysaccharide
date.
vaccine is also.
Correct. You must take the PCV vaccine. You must take the PCV booster. This is normal for all children, but for patients with kidney disease and nephrotic syndrome specifically, we tell them it's better to be immunized also with the PPSV vaccine, which is the 23 conjugate vaccine. The 23 conjugate vaccine, you can take one vaccine now and then one vaccine after 5 years.
Okay.
Booster, and that is it. Okay. It is also advisable to give the PCV, the PCV vaccine, the PPSV 23 vaccine. And as somebody said, it's also important to give the influenza vaccine because most of these children will relapse with small URTIs or upper respiratory infections, flus. So when you give this flu vaccine, the influenza vaccine, the chances of you developing flu is less. Okay, at least by maybe about what 20 to 30%, the chances are less. Basically, the chance of relapse is also subsequently reduced. So we would advise them to have a PPSC vaccine. The complete schedule of pneumococcal vaccine and its booster as well. We would advise them regarding the hemophilus influenza vaccine as well. Sorry, not hemophilus influenza, the flu vaccine. The flu vaccine. As well.
Influenza.
Flu vaccine. Okay, clear?
Okay.
Okay, so now I'm coming to the last part. So you said that this is a steroid-dependent nephrotic syndrome. Is it a steroid-dependent nephrotic syndrome?
Yes, sir.
Why?
Because
define steroid dependent. Define steroid
while
dependent.
on steroid within 2 weeks of discontinuation of steroids.
Okay, the definition is correct. The definition
While on
is correct.
alternate day steroids.
Yeah. While your definition is almost correct, it's not completely correct. See, it is not. This is
sorry, 2 consecutive relapses.
Correct. You need to have 2 consecutive relapses.
Okay.
So this is you saw my notes. That is why you got this diagnosis. See, what I'm thinking is in this case particular, this is probably the first dependent relapse. We have to wait it out and see. What I always tell my students is that, see, this is like a film. It's like a movie. You have to see, when you see chronic patients, you have to see over a period of time, and you have to see how these children really evolve. So when we say this is probable first dependent relapse, you cannot yet label as a dependent nephrotic syndrome. You need to have 2 consecutive relapses. Okay, you need to have 2 consecutive relapses when the patient is being shifted from a correct when the patient is being shifted from a daily to alternate day steroid therapy, or within 14 days of stop steroids. Yeah, he fulfills the criteria in one way because he just stopped the treatment within 1 week and then he got a relapse. That is true, but this is only the first relapse. We have to wait for a second relapse before we classify him as a dependent nephrotic syndrome.
Okay.
Right. So I think
we shall say only first relapse, no?
I think it's better to say, I think it's better to say this is a steroid sensitive nephrotic syndrome. First relapse of nephrotic syndrome of steroids for 1 week, no atypical features.
Okay.
And we can say probable infection induced relapse, but we don't have a focus of infection. Okay, that depends, because the thing is, you've seen aphthous ulcers, and my diagnosis in this patient is probable hand foot mouth disease. And when you say hand foot mouth disease, this children does not necessarily need to have the lesions on the hand, on the hand or the foot or the skin. Sometimes we are just seeing them with oral lesions. So I'm thinking that because this child has got oral lesions, this child has got hand foot mouth disease probably. So we can say an infection induced relapse, probable hand foot mouth disease is the culprit. This would be my diagnosis. Also along with dyselectrolytemia, but that you can't say clinically because you don't know the values. Okay. So that would be the full diagnosis. Anybody has any doubts? The topic of nephrotic syndrome is very vast, because I've just covered only steroid sensitive nephrotic syndrome. I've not covered steroid resistant nephrotic syndrome. If anybody has any doubts, you can ask me. Hello?
Yes, sir.
Anybody has any doubts? I'll be very happy to clarify. Just tell me any doubts on what we discussed, on any other doubts apart from what we've discussed on nephrotic syndrome. Also, I can tell you.
Sir, steroid resistance, can you please define?
So the previously we used to say that a patient is diagnosed as steroid-resistant nephrotic syndrome if he doesn't respond to treatment within 6 weeks of achieving daily steroid therapy. Okay, that means if a patient has started treatment, I'm giving you an example. Okay, if a patient has started treatment for nephrotic syndrome and his initial urine protein creatinine ratio is, let's say, 30, and you start treatment, and even after 6 weeks it remains at 20. Okay, I'm saying it's a case of probable steroid-resistant nephrotic syndrome. Now, this guidelines have slightly changed. In 2021, what we said is instead of 6 weeks, we can take the limit of normal as even 4 weeks. You can follow whatever is given in a textbook. 6 weeks or 4 weeks is normal. We say now that if the child has not attained remission by 4 weeks, or at least if proteinuria is not reduced by 50% by 4 weeks, it is a probable case of steroid-resistant nephrotic syndrome. And this is why I said that this is why I use the example of urine protein creatinine ratio of 30. See, why I'm telling you this is, for example, if the patient came with nephrotic syndrome initially and protein creatinine ratio was 30, and you started treatment on the first day that you saw the child, but at the end of 4 weeks, if you see from 30 the patient responded to 15, that probably does not mean it's steroid-resistant nephrotic syndrome, because what you can see is that in 4 weeks it is reduced by at least 50%.
Okay, sir.
Right? But if you see that at the end of 4 weeks from 30, it is still what, let's say 20 or 22. It is probably a case of nephrotic syndrome. So the revised guidelines by the international standards have said that if you see a patient who is not, who at least by 50% proteinuria is not reduced by 4 weeks, you can consider a diagnosis of steroid-resistant nephrotic syndrome. But for academic purposes, what you want to write in your exam is, if the patient doesn't achieve remission by 6 weeks of daily steroids, it is a probable case of nephrotic syndrome.
Okay,
sorry, steroid-resistant nephrotic syndrome.
Steroid resistant.
Yeah. And in that case, the guidelines are totally different, because what you would do is you'd plan ahead for a biopsy and you would start other medications, because steroids would not work for these children. And in these cases, there is always a question whether you want to do a biopsy or whether you want to send for genetics. So the question always comes with what the patient is affordable. Now, if the patient is affordable for both genetics and biopsy, do both. But if the patient is only affordable for one and you can only do one test, what would that test be?
Genetics.
100%. If a patient is steroid-resistant nephrotic syndrome and he's affordable for only one test, 100% go for the genetics before the biopsy. Good.
Okay, sir.
Yeah. Anything else? Any other doubts?
And one more, sir. If with alternate other treatments, will we continue alternate day steroids or just the alternative options?
Very good. Very good. So what? Who is this? Who is speaking?
Fathima.
Oh, Fathima only. Okay, sorry. Okay. So see, what we would do is in these kind of patients, when we realize that the patient needs an alternative mode of therapy. Now, let us suppose, okay, now I have a very similar patient who is having an almost similar history, who came with relapses. Now, he looks like a frequent relapsing nephrotic syndrome or a steroid-dependent nephrotic syndrome. Now, for this patient, what I want to do, my next phase of treatment is I want to give oral cyclophosphamide. Okay, because his age, he's only 2-3 years of age, and I want to give oral cyclophosphamide. What I usually do is, what is the protocol is, we start once we give steroids. Okay, we give steroids, make them attain remission, the protein becomes negative, then we start oral cyclophosphamide. We start oral cyclophosphamide in the prescribed dose. The dose is actually 167 mg per kg, total dose, cumulative dose of 167 mg per kg. That doesn't mean you have to give it in one go. Okay, that is a little complex. Okay, and it's a little out of the scope of this discussion. What we would do is we'll start the dose of cyclophosphamide once he attains remission, and then we will slowly taper the dose of steroid. You can taper by what alternate weeks will come down by 10 mg, 10 mg, 10 mg, and we'll slowly taper and come down on the dose of steroids while giving the cyclophosphamide dose. That is what we do. Now, if you're even giving, even if it is steroid-resistant nephrotic syndrome, and you want to give a medicine like tacrolimus, which is the medicine for steroid-resistant nephrotic syndrome, again, what we do is we start tacrolimus and slowly begin to taper the steroids. You should not stop steroids suddenly. Even if the steroids was useless, You should come down on it only slowly, taper and stop. Never stop completely. I mean,
So,
directly.
when will we start this tacrolimus? Means just when we see that it's not remitting.
No, that's not the case. The thing is, you start tacrolimus usually in scenarios where there is where you're facing a situation where you are diagnosing a steroid resistant nephrotic syndrome. So, for example, if this patient, Hrithik, he came to me, he was initially steroid responsive. He came to me, I started this time with the relapse. I started treatment. He's not responsive. Edema is being controlled, but the proteinuria is not being controlled. I've given steroids for 6 weeks. The protein create ratio began with 40. Now at the end of 6 weeks, it's probably, let's say 20, 25. Okay. And I'm not seeing any improvement. I will first go ahead with a biopsy. I will do a biopsy and then I will switch over to, because 6 weeks, there is no improvement in his protein create ratio and proteinuria. I'll go ahead with a tacrolimus. I will do a biopsy first. I will do a biopsy. This is for 2 reasons. First is biopsy, because when you start these tacrolimus and the medicine called cyclosporin are calcineurin inhibitors. Okay, they are a group of medications called calcineurin inhibitors. Yeah, they're nephrotoxic. So you need to know what is the basic situation of the kidney before starting these medicines. So we will do a biopsy for 2 reasons. One is to see how the glomerulus is and how the podocytes are before you start, and also to know what is the basic structure of the glomerulus before you start a nephrotoxic medication. Because after 2 years of this nephrotoxic medication, if the kidney becomes bad, we are going to repeat a biopsy and compare with the previous biopsy to see how far the kidney damage has happened and if that kidney damage is attributable to the medicine or not. Yeah, so we will start the medicine, but we will definitely do a biopsy, and then we will slowly stop the steroid. That's what we would do.
Okay.
Yeah. Anybody has any doubts? Any other doubts? You can freely ask me, no problem.
Okay, sir. So I'm not sure whether I'll be able to manage a nephrotic syndrome patient. As a family physician, what should I do? Because most of the patients will come with first episode. And when should I discharge that patient, such a patient, when I'm starting a steroid? I've confirmed the diagnosis. So when should I discharge? When should I follow up that patient? So what advice?
This is a very good question. From your point of view as a family physician, this is a very good question. So what I would advise is, first thing is, as Fathima said in the answers, you must be able to give a good non-pharmacological advice regarding the fluid restriction. This is very important. So many patients come back saying that nobody has told about fluid restriction. Fluid restriction is important. It is because, especially, and I want to make this very clear, especially in children who are being breastfed, because children who are in the age group of 8 or 9 months and who present with a nephrotic syndrome, you can't really control how much fluid goes inside, because breastfeeding is unaccountable fluid. So in these cases, you must be able to tell the parent that try to avoid other milk, outdoor with the formula feeds and all other feeds as much as possible. And try, if the child is adamant on breastfeeding, control try to give breastfeeding alone, but no extra fluid must be given. Because if the child is not having a good urine output, ultimately what this happens is all this fluid will go into the third space. Third space means it is going to go into the lungs, and the child will develop a pulmonary edema, and the child will come back to you bad. Okay, so that is one thing. The second thing what you can do as a family physician is tell them regarding no extra salt. Okay, as I said before, dietary restriction regarding no extra salt. Regular salt can be given. Third, no extra oily foods. Diet which is having bakery items or anything. And fourth, what I would tell you is be confident to start the 60 mg per meter square dose of steroid, and tell the patient that if there is increased edema after you start the steroid, also if there is increased edema, if there is reduced urine output, ask them to come and ask them to come to the medical college or nearby center wherever they are, because once you develop edema, then it is better to get admitted, because only in a proper center that you can have an intake output measurement and a monitoring is possible, and thereby you choose how much fluids enter the body and whatnot. So as a family physician who is probably practicing in a peripheral center, this is what you can do. Be confident to start full dose steroids, 100%. If there is no focus of infection, I want to mention this again. If there is no focus of infection, if the patient is not septic, be confident to start full dose steroid. 60 mg per meter squared, start the full dose steroid.
So what if the counts are very high? If it's 13,000 or 15,000, he has concomitant infections, and then can I start
Nothing.
the steroid?
Nothing will happen. What you should do is you should do when you do a count, you do a CRP, because if the CRP is suggestive of an infection, then of course you must. This I didn't mention. If you do counts, see, the thing is, if the patient is already on steroids, you can always find that the patient will have a higher total count and a higher neutrophil count in his blood count. The important thing to remember is do a CRP of. Most centers can do a CRP now. So if you see a CRP which is negative, that means you're clearly ruling out infection. Then you can start full dose steroids. But if you are suspecting an infection, if you are suspecting a pneumonia, if you are suspecting a urinary tract infection, because many of these children may come back to you as relapses, which is infection as an infection induced. So if you are suspecting an infection induced relapse, then better is to start on stress dose steroid. A stress dose steroid is 1 mg per kg of steroid. What I mean is, if this child is, for example, 20 kg, do not start on 2 mg per kg steroid. Start on 1 mg per kg. That is 20 mg steroid, and send the patient off to the peripheral center.
Okay, sir. Along with antibiotics also.
Yeah, you're free to start antibiotics if you suspect a source of infection.
Any renal dosing should be done in that? No.
Not necessarily, because you would have definitely sent a creat. If you think the creat is normal for age, then there is no renal restriction of antibiotics. I would always prefer that you start an antibiotic which does not require renal clearance, like Augmentin or Ceftriaxone. They're fairly safe. You can give these kind of antibiotics, Ceftriaxone or Augmentin, to start off with.
Okay, sir.
Yeah.
Thank you, sir.
Yeah. Any other doubts?
Hello, sir.
Sir, what about IV and all?
HIV, HBCV, and
Means how to give
in outpatients?
So, sorry. Two people are asking. This person. Yeah. Can you just tell me what do you want to know?
Sir, is it routine to send HIV, HBCV, and HCV in all patients children with nephrotic syndrome?
Yeah. So this is a good question. So the thing is, the Indian guidelines do not necessarily say that we have to send for hepatitis B and HBsAg and HIV before starting steroids. But guidelines abroad say that before starting the steroids, it is better to screen for hepatitis B, hepatitis C, and HIV. So it depends on what kind of center you're in. Most centers, and I started my practice in CMC Vellore. Even in CMC Vellore, actually, we do not screen for hepatitis B before you start for steroids. But the centers abroad do definitely screen for hepatitis B and hepatitis C and all before you start steroids. So it depends on what kind of center you're practicing from. But I would definitely suggest you screen for tuberculosis before you start treatment.
Okay, sir. Can we just take one more question and can we wind up the session? So one question is there in the chat box. What weight we should take, expected for age or the current weight?
Oh, this is a very important question. This is a very good question. So this is what I call the dry weight. Okay, the dry weight of the patient is the weight of the patient. The dry weight of the patient is the weight of the patient when there was no edema. Simple. Okay, the dry weight of the patient is the weight of the patient when there was no edema. So it is not. It is the answer to your question is neither of both. It is not what is the expected age, because you can have a child who is actually expected to be 12 kgs, but prior to his onset of edema, he may only have been 10 kgs. That does not mean you calculate for the 12 or for the 10. You have to calculate. I mean, you have to calculate based on what his weight was prior to the onset of edema. So you must be able to ask the parent if they know a weight of the child during the previous vaccination, and you must be able to assess whether generally speaking, you will be able to see whether the child is well developed for age, grown up for age, whether the child is the nutritional wise he is adequate for age. If he is adequate for age, yes, you can use the expected weight for age formula, and you can calculate to define whether whether the extra weight is because for edema or not. The problem happens when the child is very thin, but then you cannot assess whether what is his dry weight. In that case, you must ask the parent what is his last weight which you checked. Usually they'll have an immunization which has happened maybe 4 or 5 months previously, and you can ask the child what was his previous weight which was assessed, and that would be very close to his dry weight. So that would be the target weight you go for when you start the diuretic. The good question, very good question.
Okay, so thank you so much. Due to lack of time, I think we'll have to wind up the session.
Yeah, but I just want to say I enjoyed the questions. There's a lot of good questions. Thank you.
Thank you so much, sir. On behalf of Spice with Kerala, we extend a heartfelt thank for you to attend this session. It was really, sir, like the topic said, it was a roller coaster, but you made it very simple. Even the basic aspects were covered well. Thank you so much, sir, for taking your time. And
Thank
we
you.
hope we'll see you again in all the future sessions as well.
Sure. Can I just tell you that if anybody has any doubts, you can also contact me personally. If I know the answer to the queries, I'll be very happy to deal with them. No problem. Thank you.
Thank you so much, sir. Thank you. Thank you
Sure,
all the
sure.
participants for actively participating. And we'll hope to continue this in the coming months as well. The schedule will be put up soon. Please, all the institutional leads, please see that the topics or the case presentations are taken care of and all the presenters are ready well beforehand. Thank you so much. Have a good night.
Thank you, Fatima. Well presented.
Thank you, sir.
Good night. Good night.